Good evening, all. Welcome to SAM's Symposium under the head of Safe Anesthesia Saves Life. And today's topic is drug interaction and anaphylaxis. I would like to welcome Dr. Samrat Madnaik sir, Dr. Kirandeep Sandhu ma'am, my guru Dr. Kalpana Kelkar ma'am, and Dr. Supriya Kulkarni. I request Dr. Anita Niti ma'am to brief about our SAM Symposium.
Thank you, Rajesh. This SAM symposium, the theme is Safe Anesthesia Saves Lives. And so we have tried to take all the topics which are related to safety. And so anaphylactic shock and anaphylaxis and the drug interactions is very important part related to safety because we when we are faced with such situation, like suppose your patient's blood pressure is crashing, nobody is going to give you the diagnosis, right, that okay, this is a drug interaction or this is an anaphylactic shock. You need to come to that differential diagnosis, you need to come to that conclusion and treat it simultaneously very fast. So really we need to be abreast about the knowledge of all the drugs. As you know, giving anesthesia is a polypharmacy. So, and all new drugs keep coming. So, like those GLP agonist drugs. So, we need to know what are the problems associated with these drugs, and we need to afresh our knowledge. So, this today's symposium, and I want to welcome our chairpersons, Dr. Kalpana Kelkar madam and Dr. Supriya Kulkarni, and our today's speakers, Dr. Kirandeep Sandhu and Dr. Samrat Madnai. And it is my proud privilege to welcome and introduce Dr. Kalpana Kelkar madam, who was not actually my guide, but she has taught me so much. I have worked with her in BJ Medical College, and she has trained hundreds of students. She is a professor emeritus at present of critical care medicine at DY Patil Medical College, and she was working in emergency medicine for some time at KEM, and she is ex head of the department of BJ Medical Pune for BJ Medical Pune, head of department and professor. She retired as professor and HOD, and she was the deputy dean also. She has multiple research publications to her credit and participated as speakers in n number of conferences. We always love to listen to her. And this is not all. I mean, she is a poetess and a very sensitive human being. And in her poetry, it reflects. And she is a music lover, ardent music lover. So, a multifaceted personality. Dr. Kalpana Kelkar, I welcome you, ma'am.
It is always very nice to be among the younger generation, you see.
Thank you for being there, ma'am. Yes, please introduce Dr. Supriya. Rajesh, are you there?
Yes, yes, sir.
Rajesh?
Yes, sir. 1 minute.
Incidentally, Anita, Supriya is my student. Huh?
Oh, so it is
I
so
was the
wonderful
guide.
that you both are chairpersons in one program. That's so nice. Supriya is working at Dr. Hedgewar Rugnalaya, Aurangabad at
Yeah.
present.
Achha.
Dr. Supriya
And
Kulkarni, ma'am, she is from Sambhajinagar. She has a huge experience of 25 years in the with special interest in pain management and regional anesthesia, with pediatric anesthesia and anesthesia for critically ill patients. Presently, she is working as a vice president of SSPA, that is Society of Study of Pain, Aurangabad, and she is the honorary secretary of Aurangabad Anesthesia Association. She has presented papers and posters at state and national level and international pediatric conferences. She is a IRC trainer and coordinator at Kedgewar Hospital. She has so many publications to name few. Awareness of anesthesia and anesthesiologists in a lay people. The book is published, and relation of serum electrolyte changes and irrigation should used in the case of CRP. Uh, she did a study at Kedgewar Hospital. That's
I think she's
Okay.
another Supriya, is it? Probably.
Welcome,
Ah,
Priya.
It's from Aurangabad.
Yeah.
she is from Aurangabad. Yes,
Mhm.
okay. Thank you, Rajesh.
thank you.
Uh, Good evening, everybody. It's my pleasure to introduce our Yuva uh, faculty and today's speaker, Dr. Samrat Madnaik. Uh, he's consultant cardiac anesthesiologist at Karad, and he had done his DM in cardiac anesthesia and so many fellowship. Thanks for giving all this description here, so I can read it. He fellowship in Indian Academy of Echocardiography, fellowship in TE and mm, ECMO, then critical care. Then he had done PG certificate course in clinical echocardiography, level 1 accreditation from the Indian Academy of Echocardiography. He got Best Academic Achievement Award in 2018. He is gold medalist in the health research exam conducted by the Indian Council of Medical Research and the National Epidemiology in 2018. He is part of cardiac team that performed the first successful adult heart transplantation in KLE Hospital, Belgaum, and was felicitated by KLE University. He is selected through Maharashtra Public Services Service Commission and previously worked at JJ Hospital, Mumbai. He got President's Appreciation Award from SAMS, and he was faculty at various state and national conferences. Welcome, Dr. Samrad, and
Excellent.
over to
Excellent.
over.
Yeah.
Tha-
Yeah.
Yeah,
Yeah. Good evening,
Thank
over
you.
everyone.
to
I
Samrad.
have the
Thank you,
I have
sir.
the
Thank you.
hon- I have the honor to introduce Dr. Kirandeep Sandhu ma'am, ever smiling person. She heads the department of KIMS, Manotha Hospital, Nashik. She has worked as consultant at Wokhad Hospital for many years. Uh, she has worked as a consultant at Max Super Specialty Hospital, New Delhi. She's faculty at various workshops and conferences. She was scientific chair at Yamahacon 2022 at Nashik. MAC 21 series coordinator. She's an NABH auditor. So we should be knowing her for our hospital accreditation. And she has many awards, international and national awards. WHL Leadership Program, Boston 2010. National Award for Excellence in Healthcare for Best Quality Initiatives by CMO Global Asia Mumbai at 2000, in 2015. Winner of Best Patient Safety Initiative World Health Congress 2016. Wow. President Appreciation Award Maharashtra State ISECON 2023. Welcome, Kiran ma'am.
Welcome, Kiran ma'am. Today's both speakers are
Excellent.
excellent, young mainly, and very enthusiastic.
Yes. So,
Welcome.
Can you please start sharing?
Yes. Thank you, sir. Thank you, ma'am, for the wonderful introduction. I'm humbled, and let me start without any further delays. Is my screen visible right now?
Yeah,
No.
your screen is visible, but your video is not.
One second, sir. Just let me fix it. Yeah, now, sir.
Yes.
Hmm.
Yeah, one second. I'm just restarting it.
Uh,
Restarting
Yeah.
it. One second.
Now visible.
Right. We can see
Yeah.
yours.
Yeah.
Okay. You can see my screen. Yeah, I think screen is visible and is full screen mode. That is
Your
what I
screen is
believe.
visible, but
Yeah.
your
It is not
own
from.
videos streaming is not good.
Okay. Uh, Sir, if you don't mind, just let me restart my video again. Just 1 minute.
No, you can continue with that only. It's not
Okay.
a big problem.
Yeah. All right, sir. That should be all right then. Yeah. So
Full
yeah.
screen. Samrat, make it
So
full.
good evening, everyone. Good evening, my respected seniors, colleagues, and my dear friends. Let me thank Sam's Maharashtra.
Hello?
We lost him.
I
His
think
internet must not be stable.
Yeah.
I think he also was
You,
muted probably
Yeah,
when
no, no.
everybody was muted.
there in
I
the
think
Now,
his
sir, is it
network is
okay?
not
I think
proper.
there was some error from
start
the.
sharing again,
Yeah.
Samrat.
Yeah. Started, ma'am.
Yeah.
I
Yes.
hope this is okay now. Yeah.
Yes, we can
Without
see.
any further delay. Yeah. Good evening, my respected seniors, my colleagues, and dear friends. So first of all, at the outset, let me thank Sam's Maharashtra, all the dignitaries and the office bearers, as well as everyone for giving me an opportunity to present at this prestigious platform. Myself, Dr. Samrat Madnaik, and I'm a consultant cardiac anesthesiologist. And today, I'm going to talk on drug interactions in anesthesia. Disclosures. Anything wise in the presentation, you should credit to the many experts who have preceded me. Anything foolish, please assume it as my error. These would be the objectives of my talk. First of all, I'll go through an introduction. I'll tell you about different types of drug interactions which occur during anesthesia. There are a few clinical
Uh,
examples and what are the
Dr.
advances
Samrat,
right
The
now that are
slides are
taking
not
yeah,
place.
your
moving.
slide is not moving, I
Yeah,
guess.
Yes. The next
yeah.
slide is
Now is it moving, sir?
No, no. We are seeing only first slide, I guess. Yeah,
yes.
now
Now it's
it's
Yes,
just
taking.
now it's moving. Disclosure.
Yeah, yeah.
Yes, yes,
Yes, yes, yes.
One
yes. You
second,
are
sir.
now
There is,
at third slide. Yeah.
yeah.
problems of
Now,
online
so is it
learning.
better? Second slide is visible, sir, right now
Right
on it.
now,
No, no,
nothing.
Samrat. You can't see anything. You just
So,
see a
sir,
line.
can you just with my connection? Just 1 minute, minutes, give it to me. I'll just be back. Just 1 minute.
If Ganesh is there, ask him to help him.
So if the connection is unstable, then Ganesh will not be able.
Ganesh will not do. And all these young people know everything.
More than Ganesh.
Ah,
So all these
so,
woes of our online platform, and I guess we
yes,
are getting used.
yes, Karan madam, can you please discuss about this drug interaction?
Yes, yes.
Will he get connected?
Yeah,
Ma'am,
Samrat is
Drug
there.
Karan ma'am, please.
interaction is such a big topic. Actually, it is really very difficult to know all the new drugs and all the interactions can take place in anesthesia.
Yeah.
But
Hmm.
I'm sure that there will be many people who can be. He's back. I think he's
He's
back with
back.
us.
Yeah,
Okay.
yeah.
So is my screen
He's
visible
back,
now?
but
I think my video
Yes,
is
yes,
also okay.
Yes,
yes.
yes.
Yeah, yeah. So let me just begin
yes,
again.
yes.
Yeah, yeah. So good evening, everyone. Good evening, respected seniors, dignitaries, and all my colleagues and dear friends. First of all, let me thanks Sam's Maharashtra and everyone, including the office bearers and all the members, for giving me an opportunity to present at this prestigious platform. Myself, Dr. Samrat, and today I am going to talk on drug interactions in anesthesia. Disclosures. Anything wise in the presentation, you should credit to the many experts who have preceded me. Anything foolish, please assume it as my error. These are the objectives of my talk. I'll be going through history and introduction. I'll tell you about different types of drug interactions which can occur during anesthesia. I have a few clinical examples and the recent advances which have taken place, and then there are few key points. I always wonder how they used to anesthetize the people in olden times. Maybe like this. Well, I'm glad I'm not in that era, or this talk wouldn't be happening. A brief about history. So, in the early beginnings, that is from 1840 to 1900s, the first anesthetic interactions were documented, and these interactions were documented with chloroform and adrenaline, and mostly arrhythmias used to occur during that time. So, the first documentation was way back in 1840s, and there was minimal understanding during that time, and interactions were often discovered through trial and error. As the eras and the time progressed, then the era of discovery occurred, and the era of discovery we call between 1900 to 1950. And there was recognition of barbiturates, example thiopental in 1930, and the interactions of barbiturates associated with alcohol and other sedatives. So this was the time when the first interactions with IV induction agents occurred, and introduction of curare in 1940, which was the first neuromuscular blocking agents, was which had been introduced during that time. In 1940s, there was awareness of drug interaction effects such as prolonged paralysis. So the interaction between different inducing agents, muscle relaxants, they started to gain momentum during this era of 1900 to 1950s. Now the golden age of pharmacology is the age between 1960 to 1980s. Introduction of benzodiazepines occurred in 1960s, and opioids like fentanyl in 1960s, along with halothane and influrin. All these interactions were studied during this era. And emergence of modern anesthetic cocktails and widespread recognitions of these interactions occurred during this phase. The concept of synergism and antagonism also solidified during this era. Moving further, in the era of 1980 to 2000s, there was molecular understanding and there was discovery and characterization of cytochrome P450 enzymes and their roles in anesthesia. And this was a time when recognition of metabolic interactions was done. Currently, we are in the modern era, that is from 2000 to present, and currently we are moving towards artificial intelligence and machine learning. And these days, machine and artificial intelligence is helping us and guiding us in knowing the different drug interactions. So when I was given this topic of drug interactions, actually I thought it might be it was a very easy topic. That is was the first initial impression that I got. But when I went through the literature, trust me, it was a very complex topic, and I did not know how to put it up in front of in a short presentation. So a lot of literature is there about drug interactions and especially in anesthesia. And there are multiple different ways of projecting it. And in most of the literature, all these kinds of diagrams are seen, which I find very complicated. But trust me, I'm not going to go into these complicated things. I'm going to simplify it for you. Just to begin with, I want to tell you about the importance of interaction. Since we are talking about the topic of drug interactions, I want to tell you about the importance of interaction. Now, if you look at this diagram over here, you will see a yellow line at the top, another yellow line at the bottom. At the first instance, it seems like the yellow line at the top is way much bigger than the yellow line at the bottom. I hope everyone agrees to this. Now, I'll like to just add two lines, or I would like to introduce a few more characters here. And if you see now, the whole perspective has changed. The A line, which was at the top, and the B line, which was at the bottom, are almost near equal size or near normal. So this is the power of interaction. Another example, if you look here, this is, you can call this as object A. The lower one is object B. Object A looks like gray in color. I hope everyone agrees to that. Object B looks like white in color. Now I would like to add another interaction in this. I just add black color to this. And now if you see both A as well as B, you will be seeing it in gray color. So this is not magic. This is the power of interaction, how the visual cortex of our brain processes it. So what I meant to say here is whenever you add two or more things, or whenever you add more entities, definitely interactions occur and it leads to a lot of changes. So why should we know drug interactions in the first place? Drug interactions are a critical aspect of anesthesia practice. Anesthesiologists manage a wide array of medications and they need to combine many drugs intraoperatively. Drug combinations can have synergistic, additive, or antagonistic effects, and unrecognized interactions may lead to perioperative complications. Now, in the anesthesia triangle, there are three factors: the relaxants, the hypnotics, and the opioids. Whenever we combine these three factors, we usually call it as balanced anesthesia. Now, the drug interactions, whatever drugs we use for obtaining this relaxation, hypnosis, or opioids, these drugs they interact with each other, and there are basically four kinds of drug interactions. These are namely the pharmacokinetic, the pharmacodynamic, the pharmaceutical, and the thermodynamic. So the pharmacokinetic drug interactions is nothing but it is what the body does to the drug. So whenever the drug enters the body, what the body does to the drug, it is the pharmacokinetics. And what the drug does to the body, that is called as pharmacodynamics. So to begin with, here I'd like to give you one example. Many a times in our anesthetic practice, we come across very difficult cases or very difficult situations. Now, I would like to quote here one example. In Mahabharata, if you know, Abhimanyu knew how to enter the Chakravyuh, but he did not know how to come out of it. So many times in our clinical practice also, we land up into situations wherein we know how to induce the patient or how to go forward, but we are stuck up at multiple places in many critical cases many of the times. So this situation does not arise in our practice. Let us see how we should have a sound knowledge of drug interactions, and let us see what these drug interactions actually are. So to begin with, the first kind of drug interactions which occur, these are the pharmaceutical interactions. Pharmaceutical interactions refer to how drugs chemically or functionally interact with each other before exerting their pharmacological effects. So these reactions or these interactions occur at the formulation level, the physical or chemical incompatibility level, the competition at the receptor or enzyme or at the transport level, or during changes in drug delivery, solubility, or stability. So few examples of pharmaceutical interactions are: first, precipitation reactions, that is incompatibility. If we mix thiopentone with succinylcholine or rocuronium, there many times precipitation occurs. So this is an example of precipitation reaction. Similarly, propofol when mixed with benzodiazepines sometimes and it can give to emulsified solutions, and this again is a type of precipitation reaction. The second type of reactions are the pH and solubility based interactions. Midazolam, we all know it is a water soluble at acidic pH and it precipitates whenever it enters into the physiological pH. So if it is mixed with alkaline solution, the solution becomes unstable and drug loss may occur and it can lead to precipitations. The third type of pharmaceutical interactions is the adsorption and binding interactions. Fentanyl or nitroglycerin, we all have used this, and especially when we use PVC tubings while delivering these agents, when we connect them to the infusion pumps, in small quantities, sometimes these drugs gets absorbed or adsorbed by the PVC tubings, and this can lead to reduced delivery of the drug in the body. The fourth kind of interaction, pharmaceutical interaction, is the inactivation or antagonism via mixing. Example, if dantrolene is mixed with calcium containing solution or fluids like Rinder's lactate, it leads to chemical inactivation. Similarly, propofol plus lignocaine, many of us have the habit of mixing them so that the patient does not have pain. But trust me, sometimes it can lead to instability due to emulsification. So you should not mix or not do these kinds of mixing or solutions. A few other examples, thiopentone and succinylcholine, they can lead to precipitation. Similarly, midazolam and alkaline solution, they can lead to denaturation and precipitation. Propofol, if mixed with atracurium or phenytoin, it can lead to inactivation. Dantrolene with calcium containing fluids, example Ringer's lactate, can lead to chemical inactivation. Fentanyl gets absorbed by the PVC tubings, and propofol and lignocaine can lead to instability of propofol solution. So these are a few examples, or these are a few examples of pharmaceutical interactions. What I mean to say here is before combining or mixing any two drugs together in single syringe or any single point, you should be very careful. There is a beautiful chart which is given over here. I think the clarity is not that great, but if anyone needs it, I can send it afterwards. And if you see here, the red dots over here are the things which are not absolutely not compatible. And the green dots are the drugs which are compatible when mixed together in single syringe or in single pint. So basically, propofol along with cisatracurium or etomidate along with vecuronium is not compatible at all, and you should avoid mixing them. One clinical scenario over here. We have a 43-year-old male patient who is a known case of epilepsy who was on carbamazepine and needed general anesthesia for spine surgery. Significantly higher doses of propofol were required to maintain anesthesia, and the patient recovered faster post-operatively. What could be the reason? So here the reason is this is a classical case of pharmacokinetic interaction due to accelerated metabolism of propofol due to cytochrome induction by the carbamazepine. So basically carbamazepine, it induces cytochrome P450 and it leads to a pharmacokinetic interaction which leads to accelerated metabolism of propofol. So because of which the duration of action is very small. So with this clinical scenario, we move on to the second kind of drug interactions which can occur, and these are pharmacokinetic interactions. Now remember, pharmacokinetic interactions, they influence the absorption, distribution, metabolism, and excretion of the drugs. What do we mean by all this? But before we move further, I'd like to give you a few analogies for this. I had stayed in Mumbai. I used to work at JJ Hospital, and the Mumbai local was the lifeline of Mumbai. So call this as the let us call this as the human body and us as the drug. So whenever I used to board the Mumbai locals, it used to be very difficult at many situations. So the scene here, or I'd like to compare here this with absorption, which is dependent on many factors like the GI, pH, the motility, or the enzyme modulation. The second stage is the distribution. So once you enter the local, you go to different compartments or the people are distributed. Similarly, when the drug enters the human body, the drugs gets distributed. So this again is dependent on many factors. The third part of the journey or the third part of the travel is metabolism. Again, when you enter the local till you reach the destination, it is a huge task. So I would like to compare this with again the drugs which enter the body. And ultimately at few stations, you are just thrown out of the local. And here I'd like to compare this with the excretory part of the drugs. So basically what I mean to say here or what examples I would like to give here is midazolam along with erythromycin, they cause cytochrome 34 3A4 inhibition and it leads to prolonged sedation due to reduced midazolam clearance. So this is one example where there is cytochrome inhibition because of which the action of midazolam increases. Similarly, fentanyl along with fluconazole, it causes cytochrome inhibition. Again, plasma levels of fentanyl are increased because of this. If propofol is mixed with phenytoin, it leads to cytochrome induction because of which reduced propofol effect occurs. Ramifentanil along with beta blockers, it leads to altered esterase metabolism and there is enhanced hypotension and bradycardia. Rocurinum along with magnesium sulfate, it leads to impaired neuromuscular clearance and it can lead to prolonged neuromuscular blockade. Volatile agents along with carbamazepine, they can cause enzyme inductions and faster metabolism of inertial anesthetics can occur. So these are all examples of pharmacokinetic interactions. Coming to the third mechanism of drugs or drug interactions, and that is pharmacodynamic interactions. So if you look over here in the first image, the rower over here who is there is rowing the boat. The people are sitting in the boat. So this is like just an additive action. The main hero over here or the main driving force over here is this person who is rowing the boat. The rest of the people are just additions to the boat. The second image, if you see here, all the people are contributing to the moving of the boat, that all of the people are rowing. So I'd like to compare this with synergism. In the third image over here, you see this is a match which is going on. This is a tug of war and they're moving the boat in different directions or they're rowing in opposite directions. So this is antagonism. So basically pharmacodynamic interactions occur when two or more drugs affect the same physiological system or receptor pathways, leading to either additive, synergistic or antagonistic effects without altering the concentration of each other. So few examples of thermodynamic interactions. Suppose opioids like fentanyl or morphine, if they're combined with benzodiazepines, they lead to synergistic actions. So the action overall is potentiated. Propofol along with midazolam, again, it leads to additive sedation. It is not synergistic sedation, it is additive sedation. and lower doses are needed in the intraoperative period if this combination is used. Volatile anesthetics along with non-depolarizing muscle relaxants, they cause synergistic muscle relaxations. Ketamine along with benzodiazepines, it leads to functional antagonism. Benzodiazepines, they reduce the ketamine-induced hallucinations and the sedative part is increased. So this is an example of functional antagonism. Dexmedetomidine along with opioids or benzodiazepines, it leads to additive bradycardia or sedation. Magnesium sulfate, if it is used with other muscle relaxants like rocuronium or vecuronium, it can lead to synergistic neuromuscular blockade. Neostigmine, if used with succinylcholine, again there is antagonistic effect at the neuromuscular junction, and it prolongs the depolarizing block. Dantrolene, if used with calcium channel blockers, it can lead to additive myocardial depression. And beta blockers, if used with opioids or inhalational agents, it leads to additive cardiovascular depression. So again, a few analogies or examples over here. If you look at this is the walking escalator. The people on the right side of the screen over here, these are just standing on the escalator, and this is like just the addition. The person over here is walking on the escalator, because of which the speed is increased by a great extent, and this is synergism. While here, if you see, one bird is throwing the coil inside while one is trying to move it out. So this is an example of antagonistic action. The fourth important interaction which occurs with the drugs is the thermodynamic interactions. Now, to know these thermodynamic interactions, we should know two basic things or two basic terminologies, and those are affinity and intrinsic activity. What do we mean by affinity? The strength of binding between drug and its receptor is called as affinity. Example, you can compare this to a magnet which can attract iron coils towards it. So if the magnet is strong, the iron fillings are going to get attracted towards that magnet. Intrinsic activity is the drug's ability to activate the receptor after binding. You can compare this to the audio systems. It depends on how much volume you want. So once the drug is combined with the receptor, how much the enhancement is going to occur, or how much the activation of the receptor is going to occur, it depends on the drug, or it depends on you how much volume you can increase. So that is intrinsic activity. And if you look at this graph over here, there is concentration plotted on the x-axis and the percent binding which is plotted on the y-axis. The green line at the top, this is high affinity ligands, and the red line at the bottom over here, these are the low affinity ligands. So basically, with high affinity ligands, even at lower concentrations, percentage binding can be very good. But with low affinity ligands, that is low affinity receptors, the percentage binding is very less, even if the concentrations are very high. The next important terminology or thing that we need to know is the coefficient of affinity. So what do we mean by coefficient of affinity? So basically it is nothing, it is just a number. Just in simple term, remember that higher the coefficient of affinity, if the number is higher, then that means the drug is binding at a lesser extent to that receptor. So the coefficient of affinity for tramadol is 12,486, while for fentanyl it is 1.4. So the affinity of fentanyl for the receptor is much higher as compared to tramadol. So this is inverse relation over here. A case scenario, a patient on chronic buprenorphine receives fentanyl for induction. Despite full dose fentanyl, analgesia in this patient intraoperatively is inadequate. So why do you think why this is occurring? So for this, we need to know about the concept what I talked earlier, that is affinity or intrinsic activity. So if you see for the fentanyl, the affinity is high, the intrinsic activity is high. For buprenorphine, the affinity is very high and the intrinsic activity is moderate. So basically what happens is, on chronic buprenorphine uses, the buprenorphine displaces the fentanyl for receptor binding or receptor activation, because of which the full action of fentanyl does not occur even if you are giving full doses of fentanyl. So basically, why is this occurring? Buprenorphine's higher affinity displaces fentanyl but provides weaker activation, which leads to reduced analgesic effects. And solution here is consider regional blocks or supplementing with other modalities of analgesia, example, ketamine. A few word about other drugs that we commonly use or we come across. Tricyclic antidepressants, they inhibit the reuptake of norepinephrine and serotonin. They block muscarinic as well as alpha 1 and histamine receptors, and they can cause QT prolongation, arrhythmias, seizures, and sedations. So whenever you are using this tricyclic antidepressants, remember with ephedrine, if you are using it, then it can lead to exaggerated hypertensive response. If even if you are using it then in local anesthesia, again there is risk of arrhythmias and tachycardia and hypertensive crisis. TCS along with halothane or other volatile agents, there is risk of arrhythmias. TCS with opioids or sedatives, there is additive CNS and respiratory depression. And TCS with anticholinergics like atropine, there is severe anticholinergic toxicity that can lead to agitation and delirium. So basically, earlier we used to use MAO inhibitors. So these all drugs, they work on the same principle, and you should be very careful when you are using this combination of drugs. Just one small video how interactions can go wrong. So if you see here, the person or the doctors are examining the patient, and this is wife and child visiting him. Now there is a fly which is coming in between. He's trying to just knock it off with a defibrillator, and unfortunately they watch it at the same time, and because of this miscommunication or because of this interaction, the whole scenario or the outlook has changed. So what I mean to say is interactions are very important and drug interactions are absolutely important, and all the anesthesiologists, especially perioperative physicians, should know it. A few other drug interactions which can occur intraoperatively. We all many a times come across ACE inhibitors, patients who are on ACE inhibitors or angiotensin receptor blockers, and these all drugs can interact with anesthetics and diuretics, and they can lead to exaggerated hypotension, refractory to fluids, and sometimes vasopressors are needed if these combinations are used. NSAIDs, along with anticoagulants and selective serotonin reuptake inhibitors or corticosteroids, they can increase GI bleeding. Warfarin or dual anticoagulants can interact with antibiotics and antiarrhythmics, and they can alter the INR or they can increase the bleeding risk. Lithium, if used with diuretics or NSAIDs or neuromuscular blocking agents, it can lead to new lithium toxicity. So you have to be very careful. And steroids, again, which are many times during surgeries we use them, but if the patient is already on a chronic dose of steroid or long-term dose of steroid, it can lead to adrenal suppression. And in such patients, you need to give higher doses of steroids, or you can consider stress dose of steroids in the intraoperative period. Now, in the current era, we are coming across many newer drugs like the SGL2 inhibitors, which are very good anti-diabetic medications, as well as they are used as weight reducing agents. So basically, SGLT2 inhibitors, the mechanism of action is it inhibits the renal glucose reabsorption, which can lead to glycosuria. They can cause mild diuresis and weight loss. Remember, they can lead if these patients who are on SGLT2 inhibitors, if they are subjected for anesthesia, especially for longer surgeries or major surgeries, they can lead to euglycemic diabetic ketoacidosis. So basically, the sugar of the patient will be normal, but you will find ketones positive in this patient. So you have to be very, very careful when you come across these patients, or preoperative history taking, especially in this current era, is very important. They can also lead to hypotension and AKI due to osmotic diuresis. Electrolyte imbalance can occur due to risk of hyperkalemia, and infection can be due to increased. They can cause increased risk of UTI or genital infections. Remember, this SGLT2 inhibitors, if you know or if you have taken proper history and if the patient is subjected for a major surgery, you can try to descalate them to other substitutes, especially 72 hours before surgery. You have, if the surgery is smaller or very minor surgery, then you can hold them on the day of surgery, and you can resume them only after the patient is started, on oral, all is oral intake, that is basically oral food. And clinical tips for patients who are taking SGLT2 inhibitors: you have to monitor the ABGs and ketones. Even if the sugars are normal, make sure that the ketones in these patients are monitored. Avoid dehydration. Use direct acting vasopressors if needed. And you have to absolutely avoid misdiagnosing this euglycemic diabetic ketoacidosis as sepsis or pain crisis. So there are many instances where clinicians have diagnosed these patients in the post-operative period as patients of sepsis or pain crisis, but actually it is euglycemic diabetic ketoacidosis. So we have to be careful about this. Regarding local and regional anesthesia, we all know about this. I'm not going to go into the details, but bupivacaine, along with, if they are used in combination with other amides, it can lead to additive cardiotoxicity. They carry additive cardiotoxicity risk. Lignocaine, along with beta blockers or cimetidine, it can cause decreased hepatic clearance, because of which the toxicity of lignocaine can increase. And prilocaine, if used in high doses, it can lead to increased risk of methemoglobinemia. Now, we use many adjuvants in during regional anesthesia or along with all these local anesthetics like epinephrine. So you have to be careful when you are adding these adjuvants. And if the patient is already on TCAs or MAO inhibitors, again they can lead to hypertension or arrhythmias. Clonidine, again with sedatives or antihypertensives, it can lead to additive sedation. Dexmedetomidine with opioids or sedatives, again profound bradycardia can occur. Opioids like fentanyl with benzodiazepines or other sedatives can lead to enhanced respiratory depression. Ketamine with benzodiazepines, they reduce the hallucinations, but they cause additive sedations. The bicarbonates, which we many times add to the local anesthetics, they can increase the onset, but sometimes they can cause precipitation in the mixed solutions. Now look at this diagram. President Bush is trying to look at something. But if you see closely, the binocular flaps are closed. So whenever you are dealing with patients in the intraoperative period, especially patients who are on polypharmacy, you have to be very careful and you should be thorough with your drug interactions. A word about antiplatelets and anticoagulants. Aspirin or NSAIDs, if there is an interaction risk along with LMWH or newer novel anticoagulants, and there is additive bleeding risk. So we have this American Society of Regional Anesthesia and Pain Medicine, that is the ASRA guidelines, which are available especially for neuraxial anesthesia and use of these anticoagulants in the perioperative period. Heparin, again, if you are using during the neuraxial block or just before and after the neuraxial block, there are timing guidelines given by ASRA, and usually 4 to 6 hours before these blocks are given, heparin has to be stopped. Again, newer anticoagulants like apixaban, rivaroxaban, again, if you are using them during this neuraxial techniques like spinal or epidural anesthesia, at least you must hold them 48 to 72 hours before you are going for the procedure. Clopidogrel, again, if you are subjecting a patient to spinal or epidural anesthesia, if they can be stopped, clopid or other drugs should be stopped at least 7 days prior, at least 5 days prior before these procedures are done. And warfarin, again, at least the INR has to be less than 1.4 before you are attempting all these pricks. So all these guidelines, these are available on the internet, and you can look at the ASRA website. About the substance abuse, so in this era, many times we come across patients who are substance abusers, especially like opioids, cocaine, alcohol, benzodiazepines, cannabis, or tobacco. So all these drugs can interact with your anesthetic agents, and the interactions are quite different. Opioids, they cause tolerance as well as withdrawal. Cocaine, they can cause arrhythmias. Alcohol can cause CNS depression or increased metabolism. Benzodiazepines, they can cause tolerance or synergism with opioids. Cannabis can lead to heart rate and blood pressure instability, and tobacco can lead to enzyme induction, airway reactivity, and poor healing. A word about alpha 2 agonists, especially dexmedetomidine. So basically, dexmedetomidine with opioids, it can cause synergistic sedative or analgesic effects. With benzodiazepines, again, additive sedation can occur. With propofol, again, additive action can occur, and it whenever you are using this in combination with propofol, the dose of propofol needs to be reduced. With volatile agents, again, it has got max sparing effect. That is, the requirement of volatile anesthetics with dexmedetomidine or alpha 2 agonist is very less. With neuromuscular blocking agents, the dex may reduce the sympathetic tone, and it can cause the affect or it can affect the hemodynamic response, especially to the blocks. And beta blockers, they can cause additive bradycardias. Ketamine, they can cause partial or functional antagonism. And anticholinergics like morphine, they can cause pharmacologic reversal. Look carefully over here. What is happening here? A politician is trying to talk to the people in the flood affected area. A child is subjected to violence. But is it the truth? Well, absolutely no. So similarly, with drugs, you have to be very careful because they can lead to interactions, and you need to predict all these interactions beforehand so that the patient safety is managed in the intraoperative period. Now about this word about COPD patients and patients who have intraoperative bronchospasm. Remember that thiopentone can cause histamine release, and again there is increased risk of bronchospasm. Morphine or meperidine again causes histamine release and can worsen bronchospasm. Atracurium and mivacurium can cause histamine release, and you have to use with caution. Desflurane, isoflurane, they are airway irritants. and they can provoke bronchospasm. And neostigmine again can cause bronchoconstriction. And always remember, you have to use it with glycopyrrolate or atropine, especially in COPD patients. Now, about herbal supplements, many patients these days they are on herbal supplements when they come to us for surgeries. So basically, there are different herbal supplements which are available. So in short, so a few supplements like St. John's wort, they can cause depression and anxiety. They induce the cytochrome 3A4 and they reduce the anesthetic effects. Garlic or ginkgo can cause increased bleeding risk. Ginseng can cause bleeding, hypertension, and arrhythmias. Valerian can cause or it can potentiate sedation and it can prolong the anesthesia. And similarly, Echinacea can cause, which is again a immune support drug, it can cause allergic reactions and hepatotoxicity. So what is the future now exactly in this era, especially in the era of artificial intelligence, what is happening or what are the new advances what are happening? So basically in this era of artificial intelligence, now there are different machine algorithms and protocols which have come, which are trying to look at these drug interactions in real time. That is, the real time monitors are available, and in in coming future, that is maybe in a few years, the real time interactions between the drugs which are occurring or the affect their affection on the receptors what is occurring will be very easily available in the intraoperative period or inside the operating room. So one such system is the AIMS, that is the anesthesia information monitoring system, which is available or which is in progress or which is being they are working on it, and soon a refined version will be available. So the future OTs or the current OTs at very advanced setup, they might look or they will look like this, wherein you will have a very high-end anesthesia machine. There will be a dual cross-group controller for different managing the different agents for the anesthesia machine. There will be the anesthesia information management system, what I talked about just in the previous slide. Then there will be a closed loop controller for fluid management. There will be also different infusion pumps which will be able to diagnose or know the plasma levels of the drugs and accordingly titrate all the drugs in the intraoperative period. So the future, most of these things will be taken care by artificial intelligence, but there is still time for that. So always remember, if you look at this image, you have to be very watchful. One person over here is trying to dig his own grave over here. So whenever you are dealing with drugs in the intraoperative period, you should be thorough with your pharmacology, or else
Opposite.
problems can occur. So my take home message is a thorough understanding of pharmacology of drugs and interactions is essential. Preoperative optimization and planning helps to reduce the intraoperative events. Drug interactions in anesthesia are common, preventable, and impactful. And AI and genetic typing and targeted therapy anesthesia with closed loop monitoring and information systems are going to guide us. So there was one video which I wanted to play, but I do not have an audio system right now, so I'll just skip it. These are a few of my references. Thank you.
Thank you, Dr. Samrat, for taking us through this uh, ride of all our anesthesia drugs, what all they can do, and a very quick revision.
Absolutely.
Yeah. I want Dr. Kelkar, madam, do you want to comment on this?
It was a very informative lecture, a studied one. But I think some important interactions which we come across and which we should know have been missed out, and they are the neuromuscular blockers. The neuromuscular blocker potentiation under anesthesia uh, by antibiotics. It is a very, very important drug interaction which all of us should be aware about. I remember one case which we had done where aminoglycoside antibiotics and interaction with neuromuscular blockers is mm, a known thing which we came across where the patient had a very prolonged neuromuscular blockade after instillation of streptomycin in an abscess cavity of a patient of Cox in spinal surgery. And there we can stop the surgeon from doing that. But recently I had a phone call from one of my ex-students who had taken a patient for burns dressing, and the patient was not coming out of an relaxant effect. And she did not know. I mean, there was a big differential, and nowadays we can shift the patients to the ICU. The patient was put on a ventilator, and after digging the history, the patient had received polymyxin. So even polymyxin can give rise to potentiation of the neuromuscular blockade. So so as Dr. Madnaik very rightly pointed out, that detailed history taking and knowing which drugs the patient is receiving beforehand is extremely important, because when you are faced with such a situation, especially in a private setup, when you are single handed and when not many facilities are available, then this can be a problem scenario in private practice. Congratulations, Dr. Madnaik, for a very lucid presentation where you have given a very good classification of all the reactions, and have I think it is going to be very useful to the listeners of the talk.
Thank you,
Any
ma'am. Thank
questions?
you.
Yeah.
Yes,
Thank
yes.
you.
Thank
So,
you. Thank you, ma'am.
Question
Uh,
will take at the end, ma'am.
yes,
Yeah.
Yeah,
yes.
Yeah.
Ma-
just a word that a few one of my slides I wanted to talk about, or what I've shown.
yeah.
This ma'am, what ma'am just rightly pointed out, that you have to be very careful with antibiotics when for the drug
Mm,
interactions, especially the antibiotics that ma'am mentioned. So absolutely. So basically, these are all the pharmacokinetic interactions which occur whenever these drugs are given, and especially midazolam with erythromycin. As I earlier said, that cytochrome 3A4 inhibition can occur, and again prolonged effects can occur, or fentanyl with fluconazole, or as ma'am rightly said, that polymyxin and all these things can occur, and you have to be very careful when you are using this antibiotics, especially in the intraoperative period. So sometimes you can land up with this situation.
Uh,
We
I
have to
may
be
add,
very
if I
careful.
may add, yes.
Yeah.
If I may add, what we don't realize that cytochrome 450 is a very large family. It has got 44 subfamilies. And leave aside the drug interaction, when we are talking about pharmacovigilance, there are so many variation at an individual level, let alone two drug interacting with each other. The way they were giving an example of clopidogrel, if we look at the Indian population, 30% of the Indian population it's a pro-drug. So how it is going to act depends totally on its metabolism. And 30% of the people in India has metabolism. There is no activity of clopidogrel. That would explain. Sometimes we take patients who are on clopidogrel on an emergency surgery, and there's absolutely no bleeding. You stop them for 5 days, and some of them who are going to interact so differently with that pro-drug and are going to ooze massively even after 5 days. So pharmacology is extremely, not the good old days when you had just black and white TV and one channel, Doordarshan. Now there is just so much happening in our body, and polypharmacy is something which is there. It is a difficult topic, Dr. Samrat. You did encapsulate it very nicely. Yes.
Thank you, ma'am. Thank you.
I
Absolutely, ma'am. As you
think
rightly said, now we are entering in the era, or this is a new era. There is going to be targeted therapy which is going to occur, and
Yeah.
many I see maybe in the coming decade or 2 decades, the genetic testing for each and every patient would be available, based on which our anesthetic management will be available. So let's just see. I mean, a few decades maybe down the line, what you are saying might occur,
And
and
the
it has to
costs
occur.
have come down. And the
Yes,
costs have come down. There are
yes,
44 drug groups that we can currently trust
absolutely.
in India at a cost of
Yeah.
around 15 to 20,000,
Right,
even picking up malignant hyperthermia in the genetic. And India is a
right.
genetist treasure trove. There are more than 4,500 subgroups of genetic genomes diversities, and we in our own groups are going to interact with drugs very differently. So pharmacogenetic targeted is another new chapter as anesthesiologists we need to be aware about. Yes.
I think that
Absolutely.
is going to be very helpful, especially to prevent awareness under anesthesia.
Anesthesia. Yes.
Yes. Yes.
Pharmacogenetics.
Yes.
I wanted to give one more word of caution. Dr. Madnaik talked about all the anticoagulants, but many of the patients are receiving low molecular weight heparin, and
Yeah.
there are no tests available for its termination of action. And especially the patients who are receiving it, if they have diminished renal reserve, then one
Right.
has to be
Yes.
careful while giving the
Right.
central neuraxial block. And what actually we have to be careful about is the post-operative follow and monitoring, because if there is a hematoma, then urgent intervention is required. So especially those patients who have a diminished renal reserve, one should be careful about while stopping, isn't it? The guidelines are 12 hours before the
Yeah,
surgery, but every time that may not be sufficient, especially if the renal reserve is low.
absolutely.
Proven.
Yeah.
One more thing I want to comment, the SGL2 inhibitors that are newly available, they are there in the market, and they increase the gastric emptying time to more than 12 hours. So we need to be careful if the patient is on SGL2 inhibitors. Even if after 12 hours of nil by mouth, the patient might be full stomach
Full
and
stop.
he
Yes.
might have aspiration and problems.
GLP-1.
Yes.
Mm. So for how long they should be stopped pre-operatively to take
Uh,
care of that?
the
Um,
GLP-1, they say 1 week.
1 week. Oh my God.
Yeah.
Okay. So that may not be practically possible.
Or go for POCUS and see the gastric
That's right. That's
Volume.
right.
yes,
Yes, yes, yes.
and plan accordingly.
And use prokinetics always and confirm that the stomach is empty, isn't it?
Dr. Supriya, I want to comment.
Yes. I must say, excellent presentation, Samrat. It is a very vast topic, but you have compiled it very well and presented accordingly pharmaco,
Madam, your
pharmacokinetic, pharmacodynamic, and to be a
Madam,
so
your
everyone should be
yes.
Supriya,
while
your
using the
Your voice is breaking.
You're not audible.
Dr. Supriya, you try switching off your
I'm
video.
I'm audible now.
Your
Yes.
audio. Please try switching off your video if you have
Yeah.
poor bandwidth. Yeah,
I'm audible now.
yeah,
Yes.
yes.
Yes. Yes.
So very well elaborated. It is a very vast topic, but you have compiled it very well. Anesthesia is a polypharmacy, so drug interaction bound to occurs. And nowadays we tackle patients who are on many drugs because of so many diagnostic diagnostic era is increased, and patients are very keen on improving their health. So they are taking so many medication that we didn't come across up till now. But nowadays, like a antidepressant or anxiolytic drugs, MAO inhibitor, they are taking rampantly. And previously, we don't bother about that drugs, but we should take care of all these things. And second thing I want to add that AI is definitely going to make a change in anesthesia, because targeted therapy is going to be there in future, and we could minimize the drug interactions. Very well explained, Samrat.
Thank you, ma'am. Thank you.
Thank you. Actually, AI is long to go. At present, there are some apps available for as a drug checker, drug interaction checker. How many or which is more reliable of these interaction checker? It is we can easily use it during intraoperative or postoperative or before also. You can add these two drugs and see the interaction. So how much it is reliable?
So, sir, as far as I know, there are apps from different companies which have come up, which tell
Yeah.
you about the different plasma levels that can be attained when you are using this polypharmacy drugs. But I'm not sure about the reliability or exactly in a particular patient how reliable they will be. If you ask me my personal opinion, I know about these apps. I have gone through these apps, but I have not used them in any clinical scenario. So if any one of you has used them, maybe they won't be able to focus or give us more insights into it.
No,
Because
there is
it,
anesthesia
it is
assistant app
handy.
from Nysora.
Yeah.
Anesthesia assistant app from Nysora, but it is not only about the drug interactions. It is the
No, there are separate
inclusion app.
separate
Separate app.
app also for this, and we can check it. It is handy also, no, at in our hand. We can check that drug. But how much it is reliable, I also don't know. They are available to see. Just we can check it.
Yes, we can start our next lecture. I request Dr. Kiran, please start sharing your screen. We'll have the audience interaction and questions at the end of this lecture.
Hi. It's an absolute pleasure and an honor to be here among such distinguished people. And thank you for having me, Anita. And I couldn't have asked for better moderators or a better co-colleague, Dr. Samrat. That was an absolute treat to listen to. So, yes, I would want to ask everyone, how many of us here have dealt with anaphylaxis in our perioperative period, Uh, yes. Uh, so now most of the people are thinking probably I would mention anaphylaxis during general anesthesia, but the perioperative, the spectrum is massive. We are talking about patient under regional anesthesia, a guy who 30 minutes post-spinal has a rash all over his body. We could have a patient which is in the post-op, has been given an analgesic as a pain relief, Dynapar injection, and now has landed up with mucosal edema, or the worst tsunami that we all dread. Post induction, 15, 20 minutes into it, it's difficult to ventilate the patient, and the patient has become pulseless. And under anesthesia, the anaphylaxis takes on even more challenging because you have to pick it up in time and manage it up in time. So, what I have done for the next 20, 25 minutes is I'm taking anaphylaxis in context out of anesthesia and similarly taking anaphylaxis in context to anesthesia under anesthesia. So when we look up at anaphylaxis, we have known anaphylaxis even in 2600 BC. An Egyptian pharaoh was cut, so it's been there. We gave a name to it in 1902 by Richter and Pauli, which means without protection. It's our own immune system response. It's an hypersensitivity reaction and type 1. And for many years, we have had a very loose term of true anaphylaxis, pseudo-anaphylaxis, anaphylactoid reactions. The European Allergy Foundation around 2006 have given clearer definitions of how to put which into which category. Under general anesthesia, Mesmer and all courts, they are treated as anaphylactoid reactions till the time we can back it up with an allergy test or an IgE assay or a tryptase level to prove that it was an IgE mediated type 1 hypersensitivity reaction. So it's a life-threatening reactions, and it occurs in two situations. One is a foreign antigen, that's when our drugs are going in, and sometimes it's an autoimmune reaction which come there. We went over this Gels and Coombs classifications when we were going there, and majority of these are when we talk about anaphylactic reactions, they are allergic anaphylactic reactions, non-allergic anaphylactic. Majority are allergic, and in allergic, they are going to be either IgE mediated or non-IgE mediated. So we are concentrating on the first block, but it's also important to know many of the reactions we count, like local anesthetic, astides, they are type 4 contact dermatitis or immune reactions. They don't come into the typical classification of anaphylactic. When we look at anaphylaxis, which takes place outside anesthesia, and we look at the etiology, it is majority of the times idiopathic. We won't even know what caused it, which is in 37. Food is a very common irritant factor in there. 20% drugs, exercise, latex, hormone, insects. So that is when we're talking about anaphylaxis outside anesthesia. But when we talk about in perioperative periods, these agents are going to change slightly. So the pharmacological agent in under anesthesia, we are looking at two major culprits, which are neuromuscular blockers and the antibiotics. So anything at any time, any point can cause anaphylaxis. So that's the bottom rule. But if we look up at the recent NAP6 studies or the national audit, in that the antibiotics and NMPA are the front runners. In British studies, the antibiotics are considered as one reason, and in French, it is the neuromuscular blockers. And if we look at the IgA-mediated anaphylactic shock reactions that we have under anesthesia, besides these two, Sugamadex, iodinated contrast agents, colloids, opioids, methylene blue, antiseptics, these are the most common offenders. Protamine is another. And then there are forgotten issues. Many times you forget that these agents have been injected in a joint cavity by an orthopedic surgeon, and then you deflate a tourniquet. A surgeon might have put, or someone might have put, a per rectal Dynapar in case of an ERCP or others. So there are other agents which are also going, which could be contributing. Latex allergy was something that we dealt with for 2030, but current data, though it's still a global issue, but in Europe and other where we are latex free, it's not so much of a contributor in anaphylaxis. So when we're talking about the IgE anaphylaxis, the mechanism says there is a first exposure. So the T helper cell, it gets converted into a B cell, which has, it's a called an IgE switch, which happens. And now this cell is capable of secreting immunoglobulin E. Now, after the first exposure, these immunoglobulin secreting cells. Now, there's a question I want to answer explaining on this pathophysiology. We say this is a sensitivity reaction, patient has been exposed first time. Then how come a person who's receiving anesthesia for the first time, you've given a scoline and goes into massive anaphylaxis? The reason for that is in this picture. Now, if you look at IgE, immunoglobulin, it has sites for attachment to antigen. Patient might not have received that neuromuscular or scoline or anyone prior to in their life, but the structure of that compound has got ammonium quaternary ions. So that quaternary ions or any one composition of that thing, there is a cross sensitivity. So 10% of Indian population is allergic to QAI. So the person who has never received anesthesia ever before may get an IgE mediated reaction because of that sub-ion group, which is now getting attached and being recognized as an antigen even on first exposure of anesthesia. So once that is done, when the second exposure takes place, or here in this case, it might be a first exposure, but your the allergen is going to come on that second exposure. It's going to recognize that this is not something that we are happy to have in our body. It's going to start secreting IgE. It's going to combine with the mast cells. Now, the mast cells have very high affinity. They'll start increasing. Why I'm giving 2 minutes to this? We need to understand. That's why we will know how to manage the anaphylaxis rather than the drugs that we sometimes use. Once this coupling is done, if you look at this program, this can be a direct reaction, which is without any IgE, which is at the bottom half, or it's the upper half. This mast cell, when this antigen combines onto it, will start secreting the mediators. Most common one we all know is histamine, but beside histamine, there is tryptase, carbipeptides, but histamine is the one which accounts for the major profound effects which are going to come when we have anaphylactic shock. There are 3 receptors for histamine, H1, H2, H3, and H1, H2 are the one which are going to count for most of the effects which are going to be seen, which is at the cardiovascular system by decreasing the blood pressure, initially increasing the heart rate, but once the profound vasodilatation sent, there is going to be a paradoxical bradycardia, there is bronchoconstriction, there is urticaria, and then, of course, the GI system. When we have talked about this multisystemic syndrome, as we said, IgE, the non-allergic reaction, there's another mechanism which is coming into focus in last 5 years, which is the MRGPRX2 receptors. Now, these are mast cell G protein coupled X2 receptors. They are very exciting new studies which are coming onto there and in context to anesthesia, especially with neuromuscular blockers. So why are we discussing anaphylaxis? How common is it actually? In a general public, almost 0.1 to 2% of a population has a prevalence rate. But when we come to anesthesia, the current data is more of 1 in 10,000. So, and when I was looking at all the papers which have been presented recently in the last 15 years, the Australians and the French are really leading when it comes to allergy and anaphylaxis. And their rates are around 1 in 10,000. On an average, it is anywhere from this. interesting thing to notice is that anaphylaxis in children is far rarer. And where we do get is most of them are cutaneous reactions to a mastocytosis induced kind of a state. So, though once it happens, the reactions and the presentation and management is similar as it would be in adult. Uh, Fatalities 4%. Under anesthesia, we have 3 to 9%. And if we look at surgical complication, 9 to 19% are allergic reactions and about 6% case fatality. And there are two reasons why we lose the patient in anaphylaxis. One is, of course, the cardiovascular collapse, and the second is the laryngeal edema. Those two things, if they're not managed, we might be able to resuscitate the patient, but the brain damage would set in. So we really need to be very mindful of doing the right thing very quickly. Who are the patients who are increased risk of not coming out of anaphylaxis? People on beta blockers, people on ACE inhibitors, people on adrenergic mouth, house, and people who have a coexisting asthma, coronary artery disease, or adrenal insufficiency. So when we're inducing patients, when we're talking about good clinical practices to prevent dealing with anaphylaxis, when you have a patient who has history of these things, do meticulously ask whether they do have coexistent allergies, and then be mindful your threshold and how you administer drug to those patients becomes a little more meticulous. And thing to remember is that anaphylaxis, thankfully, in majority of the cases, is uniphasic. There's a reaction, you will catheterize and you deal with it, it's settled. But at about 20%, it could be biphasic. That is, after the initial allergic reaction and the culprit, which was kind, has been stopped, but still after 6 to 8 hours, there could be a secondary phase without any exposure to the antigen. So that's why observation of anaphylaxis, because of this biphasic, fortunately, protracted anaphylaxis is very rare, but there have been few cases where from few days and one or two very rare where the anaphylaxis lasted even weeks. Those extremely rare manifestations which have been there. Quickly going over sign and symptoms. If a patient is in the pre-op or post-op, you're going to get clinical signs. Obviously, under general anesthesia, when you have all the drapes, you're not going to get a patient would not be able to speak. But it's important to know that 90% of the patients would have skin and cutaneous reactions, and which could be itching, flushing, hive, urticarias from eyes running, itching, tearing up from mucosal surfaces. And it's important to know, besides these obvious symptoms, change in taste and swelling of tongue are very important signs to notice, because here securing the airway ASAP becomes extremely important. Respiratory symptoms are present in 70% of the patients who manifest anaphylactic reactions, from difficulty in breathing, coughing, chest tightness, wheezing, itching, change in voice, and stridor. Patient change of voice, again, I'm saying if the patient is noticing, the person who's senior most should be getting on to securing their airway fast, because it might become a scenario where we not be able to secure that airway at all. And it is difficult to predict how the anaphylaxis would pan out. Iatrogenic anaphylaxis don't give you time. It's within 5 minutes, the patient would be going towards a cardiovascular collapse. If it's a non-IgE mediated reaction, it would be most of the time a simple cutaneous reaction would not go into a cardiovascular collapse in 70% of the cases. So when we look at the cardiovascular, from suddenly fainting to becoming pulseless, your patient could have any of the cardiac. Digestive symptoms tend to be ignored as a presentation of anaphylaxis, but from nausea, vomiting, external cramps, and even diarrhea. This is not just in food allergies, even your injectable ones. And in nervous system, there's an impending sense of doom when you're about to have. The 2006 classification of quantifying the anaphylaxis, there's a diagnostic criteria, and in which it's made it clear you're not supposed to have the entire. You can have anaphylactic reaction without hypotension. You can have anaphylactic reaction without urticarias. It's a subgroup. So if you get an acute illness, after getting, you have to have at least one, which is respiratory and the combination of hypotension. Or if a person who's allergic to something can get either of the two, whether it's cutaneous or respiratory or reduced PP. In children, we take only hypotension as a criteria of hypotension, especially if the patient is subjected to an agent that they are known to have allergy to. So in a patient which is not undergoing general anesthesia at that time, you have to think of differentials in form of severe asthmatic attack, having an acute coronary event, to a panic attack, to food poisoning. Any cause of shock is there would be a part of our differentials when a patient is awake and he's telling you the symptoms. Under anesthesia, you would have to put it into context of the timing, what you were doing at that time. And it's important to know, one, what are the symptoms? And secondly, what are the severity of the system? That also would decide the management of the patient who's in anaphylaxis. Grade 1 are your cutaneous erythema, urticarias, mostly without angioedemas. But when this is followed with the cardiovascular or a respiratory or other, we are looking at a grade 2. Grade 3 is life-threatening three-system involvement, and grade 4 is when you go into absolute cardiac arrest and the worst form of anaphylaxis that you want to deal with. And our management, again, depends on this severity. Now, quickly going over the drugs which are implicated in anaphylaxis. Ma'am had very clearly pointed out neuromuscular agents, agents that we really need to be there. Mostly it's IgE. Scolin definitely is through IgE mechanisms, but there are non-IgE mechanisms, especially D-tuberculare, atracurium, and mivacurium. This is a direct histamine release which settles down rather quickly rather than going into a massive shock conditions. And among the other, rocronium is the drug which has been reported to cause maximum hypersensitivity reaction in the European literature. All the Scandinavian, Spanish, French, and all, maybe they're using it more. Maybe there might be there, but this is a group which has got more. So the question is, if you have had an anaphylactic reaction to one neuromuscular group, is there a cross sensitivity to all the others? Can you use a neuromuscular blocker in the subsequent? The current data is showing among all the drugs, cisatracurium to be the safest if you still need to use a neuromuscular blocker for a subsequent exposure. And we'll come down to the methodology of testing later on. But it's important to remember that there are non-Ig mediated. So many times they can be simply other mechanisms which are operating, especially in a person who's atopic, and those are mild to moderate reaction. And it's also things to know. Beside neuromuscular blocker, the second most common cause is antibiotics. And antibiotics, the number one culprits are penicillins and beta-lactams. Cephalosporins are a safe alternative, but all are not anaphylactic reaction. For example, vancomycin. You give this drug rapidly, there is a flushing reaction. It is almost mimics an anaphylaxis. All you need to do to avoid anaphylactic type reaction with vancomycin is to give it slowly. It's as simple as that. And what would be perceived as a major life-threatening could be avoided by just giving it slowly. And these are the reactions which are coming through, as we said, MRGPRX2 receptors. Looking at benzodiazepine, which is there. Diazepam is more likely than midazolam to cause anaphylactic, and especially in the 90s and early 2000s, there are a lot of literature, and it was the active metabolite of desmethylbenzodiazepine which was causing cross-sensitivity. And though there are cases of midazolam reported anaphylaxis, if a person has had a reaction, it's probably one of the safer drug to give on the subsequent exposure. But safely, yes, you can test it out. But when they have tested out, midazolam in the last 10 years literature has passed the IG test in most of the population who went in through the allergic reaction. What about morphine and opioids, other one? Most of them, these are cutaneous reactions with a release with direct histamine release rather than the other. And very few literature cases of fentanyl-induced anaphylaxis is present. Other common agents that we inquire obviously are the colloids. There is up to 4% of the anaphylactic reactions, and the data varies. There are decades where we put a lot of emphasis on colloid causing the anaphylactic, and there are some decades where it is not. Blood, of course, the gelatins, all. The dextrin and hydroxystarch currently are almost accounting for 0.8 out of these 4%. So generally tend to not use them. But it's important to know the same question that we ask with the propofol, we ask with a person with egg allergies, should they be receiving these colloids? Should they be receiving albumin? But the source of this is very different from what they get. So the person who has an egg allergy could easily be given albumin or any of the colloids without worrying about an anaphylaxis. So what about the natural rubber latex? Now, latex sensitization, the natural work, it comes from the source of the latex, the helico, and the sensitization to latex is reported in 12% of healthcare and 75% of the patient who will undergo multiple surgical procedures. It used to be common when we used to have spina bifida in youngsters, and they used to use these implants, and subsequently coming because there is a sensitization. Latex is also more common according to the latest guideline in orthopedic, abdominal, and OBG practice. And how do you distinguish a latex allergy from another allergy? This is at what stage of anesthesia you were. If post-induction your patient is crashing and there are not any other reasons which is contributing to that collapse, it's very likely to be antibiotic or your neuromuscular reaction. But if it's ending towards the end when your surgery has gone into the maintenance, because latex need time to interact, an obstetrician's hand inside the uterus, which is going in there, causing bloodstream. For a latex allergy, is very unlikely in the initial half. It's more likely in the second half. So when we are doing anaphylaxis is a diagnosis, it's most of the time a clinical diagnosis when you are dealing with the situation. And in the clinical equation, it is the timing which is very crucial for you to take a call. What is that is causing the collapse in that patient? And so patients who have had neural tube defects, urogenital malformation have been put into those devices and now have come for something, your threshold should go higher for those. Said that, if we can, having a latex free practice is what is advocated in most. In fact, there are places where they make emergency cards which are latex free. So if somebody has come to give an emergency resuscitation, the card is called a latex free card. Now, how do we manage anaphylaxis? Whether it's under anesthesia or the outer context, I love to say this line because those who have heard me before, there's three words: adrenaline, adrenaline, adrenaline. That's what everybody needs to know. And it is the first drug. I've gone through 3, 4 more guidelines, and adrenaline still is the drug. However, there is a reluctance on the part of people to use adrenaline as a first reaction, and we'll address that. What is the route that you would prefer giving in adrenaline? So the guidelines say intramuscular route. It is a consistent delivery. It's much better than subcutaneous delivery, so you will go there. And what is the site for giving intramuscular? Because you'll not waste time putting in an IV cannula, securing it could be whatever the reason. So you go in the thigh, the AHA guidelines. For an obese patient, rather than middle, you can go in the lower thigh, and you need a longer needle because you need to go into the fastest. Very consistent release of epinephrine, and it will start working away immediately. Under anesthesia, we intramuscular, before I come to under anesthesia, what are the dosages? So it is weight dependent. In a adult, you will go with that 0.5 ml, which is your 0.5, and but 6 to 12 years, 0.25 ml of 1 in 1,000. And if it is less than that, you can go 0.12. The dose is 0.01 milligram per kg max and intramuscular. So you will give intramuscular. Now my question is, would you give epinephrine intravenous undiluted to people? There are no contraindication to epinephrine. The only places where you need to be mindful before we give epinephrine is if it's an aortic aneurysmal clipping, which has been done recently, where you don't want to shoot up your pressures too high, rather, or it's a totally uncontrolled thyrotoxicosis case, which is present there. Otherwise, absolutely no contraindication. If you put into context the possibility of death or possibility of significant neurological sequelae that you're going to get from an hypoxic ischemic encephalopathy because of anaphylaxis, it's an absolute no-brainer. Most of the time, people for cutaneous reactions would love to give hydrocort, Avil, Dextra that we have learned in there, rather than giving anaphylaxis. The reason I think there are worries, two reasons, because people are worried when you give adrenaline, you can cause rise in BP, there can be arrhythmias, there can be pulmonary edema, all those complications. But what we are forgetting, what happens during anaphylaxis is the heart itself is a target organ. Maximal mast cells are present in myocardium, as well as in the coronary arteries. So anaphylaxis itself in a patient who is subclinical can unmask myocardial ischemia. Whatever you're going to give actually is going to counteract it. So even if there are transient rises, the benefit ratio definitely points out to giving epinephrine. When we are under anesthesia and patient has an IV excess and we are managing, would you give epinephrine undiluted intravenously to the patient? Answer is no. Anaphylaxis adrenaline dose is 1/10 the cardiac resuscitation dose. So 1 in 1,000 intravenous needs to be diluted to 10 cc, and you will give increments of half to 1 cc. 50 to 100 mics is what we are looking at the dose of adrenaline over a period of 2 to 3 minutes. In fact, it's almost diagnostic. If you have had a patient who could have had collapse by any reason, you've could be blood loss going on, maybe the pharmacological action of your induction agent. You gave too much propofol in a low EF stage or a dehydrated septicemic patient. So there is a pharmacological response and patient has gone into hypotension. Patient is showing similar changes. You're not sure whether this is anaphylaxis or this is just pharmacologically. You give a vasopressor or some fluid, the patient would improve if it's not an anaphylaxis. But if you give a low dose of 50 mics of adrenaline and your patient immediately improves, it would help you in diagnosing that this is anaphylaxis. British guidelines advise epinephrine at 50 mics to start with lower, but the Spanish, French, and the Scandinavian guidelines start with 200 mics dose. They would say give 200 because the timing is important and you need to start quicker and faster. So IV nephrine, you give it in any severe immediate. If you have a patient has become pulseless, give 50 to 100 mics bolus. That's the first thing you need to do. Call for help, your ABC circulation. Yes, you presume your airway is secured, but that has to be there over 5 minutes. And you put in majority of patients, 70 to 80%, the epinephrine dose needs to be repeated, but most of the people would settle in 2 doses. If required, if it's a refractory shock, you need to start an infusion 1 to 4 mic. So that is there. So one myth is very clear that is there a skin reaction in every anaphylactic reaction? No. Do you need to give antihistaminic before epinephrine? No. We give epinephrine as the number one drug choice. It has three, is the drug made for anaphylaxis. Alpha 1, adrenergic response will cause vasoconstriction. So your entire vasodilatation is going to be countered. Your beta 1 is going to cause chronotropic. Inotropic is going to make the heart. And the beta 2 is going to deal with bronchoconstriction as well as decrease down the airway inflammation. So, and wherever there are clinical situations, wherever there is a patient, whether it's your ER, your casualties, your ICUs, your cath lab, your wards, any location in hospital, you have to have a protocol recognition for your anaphylaxis in place. And the number one thing, you remove the antigen, whatever you think is causing the exposure. Sometimes you have not even figured out what's happening under general anesthesia, your pressures are going down. So as a reflex, get your anesthetic agents down, 100% oxygen, and stop whatever IV drug which is going on at that time. There are times people put drugs in your IV fluids and they forget about it. There are no labelings add on to theirs, and you're trying to resuscitate and the culprit agent is still going on. So stop the culprit agent exposure. And 3, 4, 5 is something you don't do in a sequence, you're doing simultaneously, which is giving your adrenaline, you're calling someone for your help, and assessing your ABC. Now, what the patient's position should be, if it's supine, a Trendelenburg up, but if it's a severe asthmatic reaction, your patient could be sitting up. You can just need to give your bronchodilators and all. And if it's an acute massive vomiting or anything, put the patient on recumbent position, but start your resuscitation. And in the resuscitation goal, they're very clear. Once your systolic BP is hitting less than 50, your cardiac massage needs to be started ASAP. The coronary and cerebral hypoxia, which comes after post-resuscitation, is the reason we lose the patients who are coming into there. And the next pillar besides adrenaline is IV colloid fluids. Patient in anaphylaxis, within first 10 minutes, 73% of the volume is distributed into extracellular. 2 to 4 liters. Uh, as I said, different guidelines. The Scandinavian French group, they advocate 30 ml per kg, which we are looking at 3 to 4 liters of fluids. The British start with 20 ml, but that's the minimum fluid that you're going to go, minimum 2 liters. So what would be the fluid choice? The first 1 liter, you can get any colloid, any crystalloid, your normal saline or ringer. But after that, because you're giving large volumes and you're looking at either ringer lactate induced alkalosis or your normal saline induced hyperchloremic acidosis, shift to your balanced crystalloid, but keep pouring the fluid. Colloids are second line in volume resuscitation. There have been no survival risk benefit with colloid, but when you're giving massive, you can give. There are no contraindications, though they are not. Massive amount of fluid, start your cardiac massage and start resuscitating your patients. Repeat the adrenaline dose. The patients who are on beta blockers are extremely difficult to resuscitate back if they have an anaphylaxis reactions. They can actually have a paradoxical response to epinephrine. So what are the drugs that you are thinking about? Glucagon. Glucagon, how would it act? Because it is acting at a different G protein level. It's not acting at the beta receptor, so it would there. How do we give glucagon? 1 to 5 milligram bolus, and it can be started with there. But one thing with glucagon is it causes profound vomiting. You need to have an RT or your airway secured if a glucagon is being given as a refractory treatment. Aggressive fluid resuscitation continues, and we give inhaled bronchodilators. They definitely do help. So Adlin is doing its bit, but albuterol through metered. How many can you give? Give 4 puffs. After 3 to 4 minutes, you can repeat another puff, maximum up to 10 puffs that you will give within the first half an hour as a bronchodilator. And inhaled ipetropia is very helpful in the treatment, which is especially on patients who are on beta blockers. And many times it could be just a severe asthmatic reaction to an NSAID or anything. So you need to concentration on the other group of bronchodilators as well. Now you have done all the bits you have given, but you're still having refractory hypotension in anaphylaxis under anesthesia. So what are the reasons? One, either you have given adrenaline too little, too late. That's the number one reason that their hypotension has become refractory now. Or excessive adrenaline, which has led to receptor desensitization. Your volume resuscitation is less than what it needs to be. You have failed to discontinue the culprit agent. So you need to identify what else was going. As I said, your tunica is deflated, your surgeon has put something in the joint cavity, there is a suppository sitting there, or there could be anything. If you can find the culprit agent and get it off, that would be there. And keep your anesthetic drug concentrations lower till the time your perfusion pressure. So your target is your MAP has to be 60 for patient to have a survival and a resuscitation. The drugs are, at this point, noradrenaline infusion, which would be going on. Glucagon is something that you can try out, and the vasopressin. But these are only the secondary line management in a refractory hypotension, which has not responded to the first treatment line. So what would be the role of AVP in anaphylaxis? Now, AVP is a last resort thing, but vasopressin acts at the V receptors. So it can help, and the bolus 1 to 2 units with the infusion of 2 units per hours. And these are in line with the Australian and Spanish, where you can consider this. If it is still refractory, there have been few case reports which have been managed on ECMO. And one other resort drug which has been tried in few literature is methylene, which has been tried in 1 to 2 milligram. And whenever you have profound vasodilatation in cardiac cases, so similarly, they extrapolated into anaphylaxis and managed those cases. Once you have managed the observation, it's important to remember, even if patient has come back, you need to monitor this patient for a biphasic reaction, which might happen few hours down the line. From there, a patient needs to be symptom-free before you can think of discharging from a critical care unit to a low dependency unit. And as I said, airway obstruction, edema is something you need to be there. When you have got there, secure your airway very fast. Whenever there is especially hoarseness, there is lingual edema, stridor, or any oropharyngeal edema, that should be done before it becomes a distress. So you had an anaphylaxis. Hopefully, the modalities we did has managed to there. That is not the end of the situation. We still need to know what caused drug and how do we manage. So there are drugs tests which we can do while this is happening, and there are tests that you will do afterwards. The drugs that you can send is histamine and tryptase level are the two things which will actually help you in there. Subsequent ones are there. We will do skin prick testing or basophil bat or specific IgE testing that will happen 4 to 6 weeks later on once the antibodies and the others come into there. And if these are failing, we can go for drug provocation testing. But it is important to know it is the accurate record and critical analysis of perioperative event that is more important than an isolated test result. Uh, so when we look at tryptase, because at that reaction time, unless you have thought it out and it's part of your protocol, you would not be sending this sample. The half-life is in 90 to 120 minutes. If you collect it before 15 minutes or you collect it after 3 minutes, it's not going to be of any value add on. So you need to collect it. Ideally, it's at a 1 hour interval. That's where you need to come. You use standard venipunctures. You need to send it in the rectum serum, or you can send it in anticoagulate, minimum 1 ml of there. And sometimes if you have been unfortunate not to resuscitate the patient, you still need to know what happened. For autopsy, send a sample from a femoral vessels, a tryptase level, because resuscitation generally tend to go 2 through 3 hours. By that time, histamine window would have gone because histamine is there which lasts less than 30 to 60 minutes. So histamine sample needs to be collected for analysis in the first 15 minutes. After that, it's there. Maximum 40 minutes, it still might have some value. And it is you manually pull blood using gentle pressure through a 20 G liters. Otherwise, you will get fallacious. Do not use vacuum tubes. And for this, you need a syringe with citrate or EDTA. It needs to be put on ice. There are very strict conditions for transfer. Otherwise, this is not gonna. So that's why histamine is very limited, because you are in a crisis situation. You can, if you have dealt with it before, be mindful and send it there. But tryptase is, especially the mature beta tryptase, is very helpful in knowing. And it's also important to know you need to send the tryptase level the next day to know what was the baseline level. If the next day baseline level is still high, then you are looking at a patient being a mastocytosis or a mast cell instability, and that's the reason he has had a cutaneous. So it's not just send there, send another tryptase level the next day. Now, patient has had anaphylaxis. The question would be, do you continue or do you stop the surgery? What do you say, Kalpana, ma'am?
Stop the surgery if it is
Okay.
not emergency.
Yes. See, there are no set standards. Each situation has to be addressed individually. Now, taking into account what is the surgery, what is the severity of the condition, what's the patient's response, and what are the coexisting. The guidelines which have reviewed retrospectively 15, 30 years have shown grade 3 anaphylaxis, whether you stopped or continued with the surgery, didn't have much difference outcome results. So you could continue in a grade 3 if you have managed to come out. But grade 4 hypersensitivity did not do very well. If you have resuscitated, it's better to abandon the procedure, come out, analyze, and come with a better plan to go in with the next day. And so now, if you get a patient who has had an anaphylaxis reaction, has survived, and has come to you for anesthesia, how would you proceed with this? Before, you need to have to know what were the agents which were used, what caused there, send it to an allergy clinic which gets tested out. Either you use the find out culprit agent, or you test out the agents you plan to use so they are tested for anaphylaxis. If this patient comes with a report of a sensitivity testing, if that report is more than 2 years old, order a fresh set of tests. When you order a fresh set of tests, that is more applicable because these patterns change. So it's not only you need to have those sensitivity, they need to be current reports in the last 2 years. Now, my question again to the audience, what is the role of prophylactic steroids and antihistaminic in preventing? We have received a patient who had an anaphylaxis the previous time. So when this patient comes in there, would we give the patient steroid and histamine? These two are not going to prevent the anaphylaxis. They won't. But yes, they would mitigate the intensity of the system, because glucocorticoids are very helpful in biphasic. They would settle down the airway edema, but it is impact is very slow in onset. It takes 4 to 6 hours for glucoid to have any effect. Antihistaminic, mostly second generation one are oral. They are not injectable ones. First generation antihistaminic are diphenhydramine, hydroxyzine. They were injectable. They would have a quicker. Oral antihistaminic take 30 to 60 minutes for its effect. And the only thing that they do is prevent itching. So awake patient would definitely benefit from an antihistaminic. A patient under GA is not going to have any benefit from antihistaminic. Adrenaline would be still a better choice for a cutaneous manifestation for a patient who is under general anesthesia. I'm not saying you cannot give these drugs. I had a patient recently who had a recent, and I felt more comfortable giving these drugs beforehand because I know at some point they would mitigate, but I still need to take precautions. Now, the question is, can you administer propofol to patient who's allergic to eggs? There were a lot of controversies initially that the lecithin is there and 1.2% lecithin patient with allergies. But lecithin that is present in an egg and the propofol which uses, it's a purified yolk derivative. The allergic reactions come from the white of there. And so a person who's allergic to egg, there is no evidence on the guidelines anywhere that he cannot be given propofol because it's a totally different source. Having said that, it's not that propofol may not, but most of their non-IG mediated reactions or dosage related. If you have given larger doses in a dehydrated patient or in a low risk, high risk patient, that is where it produces profound hypotension rather than it being there. And let's not forget fatal food and anaphylaxis. Post-operative patients could have there, it causes 150 deaths, and especially people who have underlying asthma and those who received delayed epinephrine. So anyone who has a known allergic food allergies need to be documented, and in your post and perioperative period, the management needs to be there, and it's a biphasic. Food reactions come back. When we're looking at risk management, patient who has had anaphylaxis, it's our responsibility not only to save them from there, it doesn't end there. They need to be guided to go to the allergy hospitals. We need to identify the culprit agents. The information needs to be translated to the patient so that the subsequent, there are a lot of resources which are available, and self-injectable epinephrine. We don't have EpiPen in India, the 0.15 and the zero point 0.3 milligram ones, which are easy to inject. It's $250. It has a shelf life of 2 years. So it is not a cost-effective way, but you can easily make a geometry box, put 2 syringes, 2 ampoules of adrenaline into there. So in case one breaks, and a larger needle, because you have to make an intramuscular for a person who's carrying there, they must be carrying those self-made Indianized Jugaad boxes with them. So if they subsequently have anaphylaxis to anything else anywhere, they need to be ready there. And they also need to be advised to have an ID band which says on a wristband, keeping an adrenaline, avoiding the allergen, but educate the patient. Just because you came out of an anaphylaxis, you had a good day, patient has gone back, but patient needs to know that subsequently he doesn't die because we didn't communicate to the patients. So as I said, in further reaction, identify the culprit, follow up with their patient, and specific and guidance to avoid re-exposure until proper investigation is completed for that patient. If I quickly go over the literature for this, I'll just take 1 more minute. The awareness of perioperative anaphylaxis among anesthesiologists so that they can make prompt diagnosis and correct treatment is something we still need to work on. And tryptase level is very helpful in identifying it in there. So we need to have a methodologies. We need to have those syringes and put into the chart, because this still around 1 to 2 hours, you can still send a sample, and it's easier to send than histamine. And crystalloid volumes, large volumes are needed in anaphylaxis. These guidelines have been upgraded onto there. And it's important that we mention our records and send it across to the people. so many reviews done, so many there. Adaline remains the first line treatment for cardiovascular abnormalities. It is not contraindicated, but larger doses you need to be careful. You can still cause damage. The other second line drugs are second line, but if it is there, you need to use them. And an accurate record of the event is more important. And remember, rocuronium has a higher IgA mediated than vicronium, and cis-atracurium has the lowest. So maybe asthmatic, we still tend to think, oh, atracurium used to have, but cis-atracurium is the safer option with a patient who has asthma. And tryptase, as we said, is the timing of the tryptase and follow up the tryptase the next day, the values which are there. And antibiotics are one of the most common causes. If we look at good clinical practices, don't give too many drugs too suddenly. When you're trying to induce a patient, at the same time, someone is giving MSAT, someone is giving pause, someone is adding an analgesic into the drip. Polypharmacy, especially at time when you are expecting an induction, you don't match up too many drugs. Label all your drugs, giving your antibiotics slowly, diluted in 20 cc, 100 cc, timing it before so that everything doesn't happen at the same times, are few of the things which would help you in preventing the anaphylaxis. I am happy to take the questions. Thank you, everyone, for your patient listening.
Thank you. Thank you, dear Kiran, for
Excellent.
Thank
presentation.
you. Excellent.
Excellent
Kiran,
presentation, ma'am.
Kiran ma'am.
Yes, sir.
Hello. I just want to add one thing. What happened in our small hospitals? The adrenaline get expired because we are not using it routinely. Uh, so epinephrine or adrenaline, if even it is expired, we should use it because it
Yes,
retains.
still use it.
Don't rush for the new one, or don't wait for getting the new adrenaline ampoule or epinephrine. So that is the most important thing. Two, 3 times it happened here that the adrenaline was expired, so they are not giving the adrenaline and they are waiting for the new one. So I just want to add this.
Yes, definitely you shouldn't wait for adrenaline to expire, and you
Yeah.
should have a system in place which will tell you that
It's a
your
very cheap
expiry
drug.
was.
It hardly costs 30
Yes,
bucks. So it's
Yeah.
something which should be replacing frequently.
yes, yes.
Yes, but
But
having said that, nothing, it's
yes,
the delay which is going to make you lose the patient rather than,
And there
yes,
should be a protocol. Adrenaline should always be available because it is the
yes, ma'am,
lifeline. Yes.
absolutely.
Always available, but sometimes it get expired. Nobody is looking after the expiry date because it is not routinely used here
So
in
that's
small
why we
places.
have to insist that even if it is not
Yeah,
used,
no.
it has to be tested that the expiry date is not over and
Yes,
it has to be
now it's
replaced.
routine, but previously it was not like that. Now
mm,
it is routine to check it.
And other thing I would want to add, when we are using
option.
adrenaline, not only adrenaline, but there's another drug you must have is phentolamine. Any extravasation now, because Dr. Kiran said adrenaline, 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 but you need to inject it in the right. So you need a large bore peripheral vessel when you are injecting. And in case you do have an extravasation, now extravasations can be horrendous for that patient if you don't deal with it. So if you have, the thing is to stop the infusion immediately. If you have an adrenaline infusion which is going on and you have a peripheral extravasation, do not flush. Do not flush that extravasation. Gently aspirate, and while you are expirating that extravasated solution, remove the cannula and you initiate phentolamine, about 5 to 10 milligram, which is diluted over 13 into that extravasated space. A dry, warm compress to just kind of, because it's a vasoconstrictor, you can actually lose out into there. Other things that you could use is anti-G or a topical, because you could have extravasated adrenaline complications. So if it's a unit which has got an ICU and other, and an emergency drug card which contains everything like your fluoxetine, your last, your lipid, irrespective of whenever any crash is there, should also have a phentolamine. present
Yeah,
there. Yeah.
we actually used to use Xylocard and
Yes, Dilocard. Yes.
hyaluronidase injection. The
Hyaluronate.
Yes.
diluted
Right.
hyaluronidase so that it gets it spreads,
Yes.
in the patient
Yes.
veins and it doesn't stay at one place.
Anita, can I say something?
Yes, ma'am. Please, Kiran, please
Yeah.
stop sharing so that we can see in the
Oh,
gallery
yes.
view.
Sorry. Sorry. Sorry.
No, no, fine, fine. Yes, ma'am.
Dr. Kiran, excellent
Yes, ma'am.
talk, I must say. I'm just going to tell you one of my cases.
Yes,
One
ma'am.
lady for cataract surgery, and I was there as a standby, just giving a mild sedation. And the surgeon, usually our ophthalmologists, give the local blocks. So he was giving the local block. Patient started getting urticaria. So I asked him to stop immediately, started giving, hydrocortisone and Avil and all that. And, she started even getting a little laryngeal edema. So, of course,
Okay.
we managed without intubation. And then
Yes.
with bronchodilator and all that, we managed. And the same case, we did it under general anesthesia after a few weeks.
Okay.
So, which is, I mean, we don't talk about so much of local anesthetic allergy, but he
Yes.
was giving
Ma'am, the
such a
esters,
small.
yes, very right. Esters have, ma'am, 1% chance of anaphylaxis. Mites tend to have much lesser anaphylactic predation. But fortunately, even with these local, most of them are type 4 contact dermatitis kind of reaction. But you have very rightly raised that even locals can produce, which is a very valid point. Similarly, what we tend to ignore is chlorhexidine. In fact, in the recent current review studies, almost 30% of chlorhexidine induced anaphylaxis reactions are underreported or underestimated. And in this, povidone is lesser, chlorhexidine has got more, and that's again the ionic compounds which there is a cross reactivity to people. Especially, it's important to know if you're putting central line which is chlorhexidine coated, or you're putting a silicone gel which is coated, or you're putting a chlorhexidine coated mesh inside a patient. It can create a havoc, and these have been picked up later. So anything we add on, it needs to be there. Especially chlorhexidine has been implemented in a lot of, and povidone iodine. If you want to check povidone iodines, the recommendations are, because it's mostly, don't check the wet povidone on the skin. You need to check the dried one, because with the prolonged exposure, even the wet one will show some skin reactivity and you won't get a proper result. So if you're testing for these local antiseptic solutions that you're applying locally, they also need to be tested.
Because the same patient was done after a few weeks. That time also they
Yes.
must have used the same antiseptic, you know,
Yes. Yes.
disinfectant. Yeah. So
Kiran,
anyway, it was
Thank you
a,
for sharing, ma'am. Yes.
I mean, and as
Yes.
soon as he started injecting, and actually, ophthalmic blocks, they need such a small quantity of local
Yes.
anesthetic.
Yes, ma'am.
Even then, the patient had. And another case, one lady, this was about 30 years back when we didn't have USG and all those things. The patient was to go under, IVP, and they inject the drug for taking the X-rays of intravenous pyelography.
Right.
Huh? So
why
that
allergies are
patient
known?
had
Yes.
told me
Yeah.
she was allergic to kumkum, and
Yeah.
any color. If she gets in touch with that color, she gets allergic
The
reaction.
dyes, ma'am, they are known
Yeah.
one of the, and these are IgE
Right.
mediated reactions. These are going to have
Iodine.
profound impacts. Yes. Yes.
So,
Even I
I
have
mean, they
seen
had to do
about.
it. So I thought, let me give hydrocortisone, Avil, other things beforehand, and we'll see when he starts giving injection. So as soon as he started giving injection, she started having urticaria. And in that case, I gave intramuscular adrenaline. The patient came out well. So, I mean, the
The
typical case of
it's
dye allergy.
anaphylaxis, yes.
Yes.
Kiran,
Kiran, I have.
many times, most of the anesthesiologists hesitate to give adrenaline because everybody is fear of that adrenaline. So it is too late at that time. So at what time we should inject adrenaline? That is, this
So
is
the
anesthesia.
Yes. Sir, the thing is, many times A will ward में थोड़ा सा reaction हुआ. Those are non-IG mediated cutaneous
Yes,
reaction. Even if you give nothing, you stop the agent, they are going to recover on their own. Body produces endogenous epinephrine, and those reactions are taken care of. They're not going to have any profound. But because of this, we have got this myth that give Avil hydrocortisone. Avil
yeah, yeah,
hydrocortisone don't start acting before 45 minutes. By that time, histamine is already
yeah.
totally metabolized by N-methyl and is out of the circulation. That's why if we take a sample after 40 minutes, 60 minutes, there is no histamine into the circulation to pick up from there. So those cutaneous. But because anaphylaxis is very unpredictable, and iatrogenic tends to give you very little time. So if this was an oral antibiotic, you will get 60 minutes. If it was an injection, you'll still get 20, 30 minutes. But iatrogenic, which is genuine IG, within 5 minutes, the patient can sink horribly. And if we anesthesiologists, 1 in 10 diluted, you're giving a 50 mics adrenaline, we shouldn't be afraid of it.
Yes, yes,
That's
we should
IV,
not
or
do.
even
Yes,
giving 0.15. Even if you get transient side effects, they're
Yes.
very transient, but the damage is there. So all the guidelines say, even for cutaneous, especially in a hospital setting, adrenaline has to be the first choice, not your steroids, not your antihistaminics. Give a 50 mics of if you have got an IV excess, or you give zero point 0.5 mics. You can give 0.35 mics of intramuscular to keep ready for the other one, but that's the preferred choice. Or you just stop the agent, stand ready with your adrenaline over there if you need to. If you don't want to give adrenaline, be around there with everything arranged, your fluids, your airway, your crash cart. If it's a mild reaction, but you need to be ready to give that as a first option.
What
under
about
anesthesia, you
spray?
always have the IV line, so you should not be afraid of giving 50 mics of
Yes,
adrenaline.
absolutely,
Yes.
ma'am. We should not be afraid of giving. As I said, there is guidelines clearly says there is absolutely no contraindication, even
We
if
had one
transient.
case.
As
We had one case
yes,
of very, very severe reaction to suxamethonium where we had to give adrenaline infusion for a very long time, and he was a
yes,
pulseless patient for a very long time. Afterwards, he made full recovery. And
yes,
secondly, what I want to insist upon is then when there are reactions to the IV, the fluids, like the reaction to hemaxil, the patient is already bleeding, we are using colloids, and there is a reaction, then it becomes a real problem because we have to give
yes,
fast fluids. At the same time, the patient has gone in a reaction, so the requirement of fluids increases tremendously, and then we have to pour in crystalloids. So that,
yes.
and second
Substitute to
one thing,
crystalloids and get blood, ma'am. The get blood
yeah, right,
products.
right.
And
Yes,
now the
yes.
transfusion
Yes.
guidelines are almost, you can let the hemoglobin drop to 7.5 in a
Yeah,
patient
but
who doesn't have
there are
any other.
scenarios like, PPH, where we
Yes,
are
yes,
not expecting blood loss and suddenly the patient goes in PPH. So that can be a
yes,
really trying. And what one more thing I wanted to insist is antibiotics. They are the biggest
yes,
culprits and analgesics also. So in the post-operative period, the anesthesiologist has to be very, very careful because I have those patients have come to me, those anesthesiologists. Dynap are given afterwards and patients succumbing to that reaction because
yes,
the
ma'am. Yes,
anesthesiologists and the trained people were not available that time. And even antibiotics, we have to be really firm about the administration of antibiotics, especially the orthopedic surgeons. They want the antibiotic to be given at the start of the surgery. We have to be careful. We have to titrate the dose, give a test dose, and then give the full dose. Because as you rightly said, at the time of administration of anesthesia, as it is, there is polypharmacy. So one has to be very careful about the antibiotics. I have known cases where the patient has undergone a malignancy surgery and patient has had a cardiac arrest at the end of the surgery because of the antibiotic. So
yes,
these two things we have to be really careful about. And vecuronium, there is a very interesting correlation between nail polish and vecuronium. Those
yeah,
people, patients who
yes.
are, who are using nail polish, that acts as a, I mean, what is that? Complement like thing. And there can be severe anaphylactic reactions that has been published also, vecuronium.
Those are
Uh,
atopic patients. They had
yeah,
the reaction and then you put the two. Yes, there have been case reports. Yes.
yeah.
There's this question that Dr. Naina has asked. Does orogreen cause anaphylaxis? Yes, any dye, any substance in an atopic could cause there, and one needs to be ready with there are very few cases, very few. It's come in new because now they have these compatible navigation systems and navigation. So these more of orogreen. Our experience initially was with methylene blue. Methylene blue is known to cause too, but it's also used as a management tool. But with methylene blue, one needs to be careful. If the patient has G6PD deficiency, or patient has pulmonary arterial hypertension, or there is an acute lung injury, then methylene blue should not be given. No. Yes.
And
What about
I want to ask, you want to give 50 milligrams of adrenaline, but what about in a pediatric patient? How many milligrams per 50
If the
micrograms?
dose, if it is less than there, we calculate it by weight,
I think
0.01 mg.
4 mites
So
per
point,
kg or something.
yes,
150.
yes,
That
Yeah.
6 years is
yes.
150.
You can confirm
I
it. I might be wrong,
mm,
but then there is a microgram per kg dose which is given.
microgram per kg. And in
Mm.
fact, less than 10 kg, the dose has to be calculated according to weight.
Mm.
10 to 30, you could give 0.15 mg. From 30 to 49 kg, you could give 0.3 mg of epinephrine. And more than that goes 0.5. So intramuscular doses are pretty clear. But less than 10 kg, you need to calculate according to the weight.
The
Yes.
per
And
kg
second
what
dose
one
about
has to be
Point.
very early in
Second dose the
intubation. You have
same as
already
the
mentioned
first.
that.
yes? What about the
Kiran,
nasal spray and endotracheal tube installation of adrenaline?
You can do it. The dose has to be 2 to 2.5 times more than this.
For
So
nasal
you will
spray?
have to inject 3 tips and then you connect it, give 4 puffs out of there as usual you would give
Yeah.
with any other inhalation. But the dose you need to hike it to 2.5 times. So you'll actually have to put 2 ampules in that 1 in 1,000 and then inject out there if nothing else, etc. But you can give. But
especially when no
intramuscular
IV line is
availability
available.
is better than the endotracheal tube availability. More consistent concentration would be achieved by intramuscular than by your inhalation for adrenaline. Though you can
Nasal
do
spray?
that 2.5 times.
What about nasal spray?
Intramuscular is the better, more item.
Okay.
Yeah,
We
because
took
if they are
question.
secretion, it's coated, how much actually goes in into there, how much is absorbed in there. So it's better to just go with the guidelines. If you have no excess intramuscular, subcutaneous, no, it's very erratic. And endotracheal could be considered, but intravenous. All the three routes are there with you.
We will go to the chat box for the question and answer. People are waiting for the answers.
Okay.
The first
Let's see.
question is
No, we have taken the first question by Naina. There is one more question.
uh,
Comment on allergy to local lignocaine.
lignocaine a patient
Had
had.
make history of same during prior dental procedure. Now patient comes to Europe for Euro procedure under spinal. How to go about drug to be used and cross reactivity to local anesthetics, is it there?
See, for this, you need to get a SPT, the skin prick testing for there, and you go by the field side. So you need to send it to allergy. So they'll send it out into there. All the groups that you want to set into there. And though there is cross reactivity, so if you're planning to use ropivacaine, bupivacaine, whichever one, they all need to be individually textured, not just one group which you are planning. So one is skin testing. Sometimes the IgE are very nice, which is done 4 to 6 weeks post that exposure. That timing is important for antibodies to come. But SPT is better than IGs, or you do a drug provocation test. Drug provocation test has to be done under supervised condition in extreme diluted, but they give very good results too. Other new things which are coming in allergy is the BAT, the basophil, how the basophil is going to respond, especially the local amides. You give into there, how they're going to there. So we call it the BAT test. So the allergy guys, depending upon the exposure, will decide which one. So generally they will start with SPT. If you get unequivocal result, they will advise you an IgE serum assays, or they will ask you for a drug challenge test or a BAT test. But you need to get all those tests. Sometimes we think thoda sa IV देख के देख लेते हैं, होता है कि नहीं, but you need to get it documented through a proper allergy testing, and then plan out which one you want to use. Most of the time, you can avoid that drug and use something else in its place. And but you need to be mindful that this patient can have anaphylaxis, then do all the ABCs. Yeah. There's this question on Sugama Dex, I think.
Yes, Sugam.
Yeah.
It is known actually to be allergen.
Yes. So Kamadas itself is Niaita. And if you have to use a muscular, you said she had allergic reactions to some white injection. Now, the white injections we are looking at is propofol or etomidate. But propofol reactions, as I said, fortunately are not that IgE. Half of the time, you're not using propofol the way, hypotension ho gaya tha. So you need to be right. Again, you send this patient for IgE testing of the or you avoid propofol. You can use midazolam, dexmedetomidine. Ideally, I would not advise without a sensitivity testing. Make sure they are done. Sugama Dex is not the first obvious choice, because if you look at the non-depolarizing muscle relaxants, they still tend to cause there. I would rather use a cisatracurium and reverse it with the neostigmine glycopyrrolate complication than Sugama Dex. Or test out your Sugama Dex in allergy testing and then go with the combination of those two.
I know about the allergy testing, we really have to be very particular. The patient has to come for many, many days when we are
Many
testing,
days,
because
yes.
all the drugs have to be tested. If there is a previous history of allergy, when the patient is to be taken up again, we have to see the detailed notes and we have to try each and every drug with proper dilution, and it has to be tested and seen. So it really needs
There is
patience.
this question. Yes, ma'am, very right.
Yes,
There's this
yes.
question by Dr. Deepak Goyal. They have given hydrocortisone and the urticaria disappeared. The same thing I'm telling. It's a cutaneous reaction. Even if you don't give hydrocortisone, that reaction, the moment you stop your aging, would have anyway stopped in 10 minutes.
I would
Yes.
say that hydrocortisone definitely has got a stabilization of the lysosomal membrane.
Yes.
So the prevention,
It
as you rightly said, biphasic reactions are avoided. So it is always safer to give steroid.
can
Right.
give steroids, but they are not the one which are taking care of the
Right,
urticaria.
right. Adrenaline has to
They
be
are
given,
not
but
that.
at the
They
same time,
will
you give
definitely
steroid
make
also.
patient feel better because it stops itching. So the patient definitely feels better because itching. But hydrocortisone IV would take about 10 minutes. Your urticaria, most of the time, many times we give morphine at induction or fentanyl, you'll see a little bit of urticaria coming. And we have
That is
neither
a
given
local relief.
hydrocort,
That is a
nothing.
local
After
relief.
5 minutes, it's gone,
Yeah.
Yeah, Dr. Kiran, I just want to share my one case of anaphylaxis.
Yes, ma'am.
Elective seizure was done. It's a Muhurtaka seizure with proper pre-anesthetic evaluation and all. Intra patient has a little bit flabby uterus. So gynecologist asked to give me a methargine along with the pitocin. The surgery went well, and after shifting to recovery room, the surgeon again asked the sister to give prostodine, that is carboprost.
Yes.
There
And
are reactions to come.
I went for my second case, and after 15 minutes, the sister came to my OT and told me that patient complained करते कि श्वास घ्यायला त्रास होतो. So I thought it could be because of prostodine, and she told me, surgeon asked me to give prostodine, so I gave that. So I thought it could be because of prostodine. So I went into the recovery room. So I saw the whole rash on her body, and spasm was so severe, it could not be like a prostodine spasm, and the BP started falling. I immediately thought of the anaphylaxis reaction, and I gave 0.5 ml of adrenaline IV, because you know that maternal death is so much of chaos.
Yeah.
I thought of giving adrenaline at that moment. I gave IV adrenaline. By that time, she developed severe laryngeal edema. I have to intubate that patient, and I have to give second shot of adrenaline. After 5 minutes, I gave second shot of also. We need to ventilate that patient for 24 hours. And after 24 hours, she came out of that. But just because of adrenaline, I could save the patient. And
Yes. Yes.
second one, that Kalpana madam told that never take antibiotic as a casual drug.
Casually.
Yeah.
Yes.
So one patient, she had a neurogenic bladder and she was in catheter. So she used to come for catheter change. So just she came for just a urethral catheter change, and it was under local, means no anesthetist was standby there. The other case was going on, and the surgeon asked the nurse to give the antibiotics. And after giving antibiotics, before they could start the procedure, patient suddenly started dyspneic, bradycardia, hypotension, and almost near arrest. We have to just resuscitate the patient. So during resuscitation, of course, we gave adrenaline, but that is because of antibiotic anaphylaxis. Of course, we have to intubate that patient and again shift to ICU. But again, that we could save that patient. So just adrenaline is the choice of drug in anaphylaxis. No other drug can save the patient.
Because adrenaline is the
Yes.
pharmacological antagonist of histamine, directly reverses all the
Yes.
actions of histamine.
Yes, yes.
So it is the cornerstone of management, no doubt about it.
Uh, Anita, madam,
Yes.
it's now 8:40.
Yes. Yes.
The discussion will not stop
I know.
because
I know.
it is it is
Yes.
interested.
Have we answered all the questions? About the nebulization intranasal, I think Kiran has answered that question.
Already
So
answered.
I
Very
think
well
maybe
explained, Kiran, madam.
Just one word regarding
Vancomycin, yes.
yes.
yeah,
Sorry,
yeah,
Samrat, go
Dr.
ahead, go
Samrat,
ahead.
yeah. Just one word regarding this anaphylactic reactions, especially the use of echocardiography now has increased in the operating room. So definitely, I would like to just add a few points regarding that. So basically, when these anaphylactic reactions occur, and if you have an echocardiography machine at your armamentarium, especially in the inside the OT, in the initial stages, usually it is a kind of a vasoplegic shock along with dilated state. So their fluids work. So you can do a quick assessment of your IVC as well as you can have a look at the ventricles. And if they are underfilled, you can give volume during this phase. At a later stage, when anaphylaxis progresses, if it does not respond to your standard treatment and when it progresses, then sets in your myocardial depression. So your management during the later stages of anaphylaxis is quite different as compared to the earlier stage.
Yeah.
Similarly, especially in cardiac surgeries, many times we come across this allergic or anaphylactic reactions when we administer protamine to the patients, and mostly
Yeah.
it is limited
Yes.
towards the right ventricle. So the right ventricle, many times we see PA pressures getting increased, the right ventricle getting dilated. So in these situations, yes, we need to give some doses of steroid. Here, the treatment
Yeah.
guidelines are slightly different as compared to your standard treatment, but the steroids along with a dose of Avil and some small dose of adrenaline helps in these situations. But if echocardiography definitely comes, helps in a big way, especially when you are clueless about what's going on.
Yes,
Yeah,
sir.
because you do get certain after 1.52 liters, you're kind of, okay, I've given enough. Do I need to give more? The echo does help out. It's still dilated like anything. So you still need to pump in more volume. Yes.
Absolutely.
And
Yes, sir.
Avil and hydrocort, see, we are saying Adlin is number one. That doesn't mean the
Right.
poor cousins are there. They have their own role, but
Right.
adrenaline is the lifesaver, is the
Especially
main
the capillary
protagonist here.
permeability.
You have
See,
those cute side
yeah.
characters who make the
Yeah.
movie very interesting, but
Yeah.
your main protagonist here is adrenaline, adrenaline, adrenaline.
Yes,
By
Samrat
the way,
sir.
excellent presentation, ma'am.
Samrat sir,
Thank you. Thank
one question to you.
Yes, yes, sir.
We
Yes, sir.
are going towards now TIVA, total intravenous anesthesia. So most of the people doing that. It is polypharmacy only. So
Yeah.
what precaution we should take during this TIVA? What is
Uh,
for drug interactions and it?
Right. So the doses of the drugs, whenever you are using multimodal kind of drugs or when you're doing polypharmacy, you need to keep in the mind that all these drugs can have additive or, as I said, synergistic effects. So when you are combining opioids along with propofol, definitely some amount of the dose reduction is necessary, which you have to keep in mind. And as I already have discussed in my presentation, many interactions can occur.
Yes.
Especially, yeah, that if you are using opioids along with benzodiazepines, then the requirement of whatever the other agents or the neuromuscular blocking agents, even their requirement slightly is reduced sometimes. So all these things have to be kept in mind when you are dealing with TIVA. To be very frank, sir, I would not be a great resource person for talking on TIVA because I mostly deal with general anesthesia and my patients are
Yes.
usually intubated. Yeah.
No, but
Okay.
always
Okay.
remember giving tailored doses.
Yeah.
Graduated
Gradual,
administration is
slow,
the
titrated
Right.
doses.
yes,
Right.
Yeah.
titrated doses. Yeah, I was not getting that word.
Yes.
Titrated doses.
Titrated
Not
doses,
Titrated doses.
except
yeah.
except choline.
Yeah.
Give titrated doses.
Right.
Yes.
Okay. Thank you very much.
Thank you, sir. Thank you, ma'am. Thank you, everyone.
Yes.
Okay.
So
Okay.
Thank you
we
all.
can actually wind
I
up
think,
the session now.
Yes.
Uh,
yes, I
Wonderful,
think it is a
wonderful
time to,
presentation, Kiran. Very nice presentation.
Thank
Both
you.
the
Yeah.
speakers did a
thank
good
you.
justice.
Please do the vote of thanks.
yes, this is time to
Before
give
the
vote
vote
of
of
thanks.
thanks, can I say something, Anita, or should we?
We'll
Uh,
stop recording, ma'am. Yes, right.
The topics were very much interesting. I thought I again went to a medical college and listening to madam very carefully. Uh, I would like to thank a very heartfelt thanks to the speakers of today's times webinar on drug interaction and anaphylactic reaction, Dr. Kirandeep Sandhu ma'am and Samrat Madnaik sir. Your expertise and insight were invaluable. The session was informative and engaging and beneficial for our professional growth. On behalf of SAMS, I am thankful to Dr. Kalpana Kelkar Madam, my guru, and Supriya Kulkarni Ma'am for their guidance and moderation. Many thanks to SAM's webinar organizer, Dr. Anita Niti Ma'am, Dr. Avinash Bhosle Sir, and Dr. Saurabh Berde Sir. Lastly, to all the delegates who participated and engaged in this symposium, thank you for your enthusiasm and interest. Thank you all.
Okay. Thank you. Thank you very much. Good night, everybody. Good night.
Thank you, sir. Thank you.